Hello, everyone, and welcome back to the Psychiatric Mental Health Nurse Practitioner Exam Review. Today, we're going to be talking about the Advanced Health and Physical Assessment. So the reason as psychiatric mental health nurse practitioners that we need to be able to detect underlying medical problems in our patient population is because oftentimes we are the only medical provider that they will see. For various reasons, people may not follow up and do their yearly primary care visits or go see specialists. Particularly, we may see patient populations of people who are homeless and things like that, who just don't have the ability to follow up with primary care. So it's important that we are able to screen and detect for medical problems so we can kind of explain to them the importance of following up with primary care or be able to get them the services that they need. We should be familiar with screening for neurological exam. This is because oftentimes if neurological things are going on, it can present as a psychiatric problem when really there's actually something neurological going on. We should be able to differentiate between normal and abnormal signs and symptoms and know when to refer out to somebody else. Done by the psychiatric mental health nurse practitioner in the context of the psychiatric care role. Our goal is to identify the presence of psychiatric disorders, general health status, and screening for non-psychiatric disorders. And we want to be able to accomplish a differential diagnosis to determine the client's needs. And because of the brain-based nature of psychiatric disorders, we are required to perform an in-depth neurological exam. So first, let's talk about the mental status exam. The mental status exam is a combination of various different things. So that's what we're going to talk about. So the first part is we're looking at the general appearance of the patient. What is their behavior? What is their attitude? What are their speech patterns? Sometimes they might be very soft. They might be very loud. They might be very fast. All of these things can kind of give us hints to what's going on. They might be very slow. So it helps with our diagnosis. We want to look at their emotion. So when we talk about mood versus affect, so mood is how the patient says they feel. So when you say, what is your mood today? They might say, I'm happy, sad, angry, annoyed. That is their mood. Their affect is what you physically see. So somebody could tell you, I'm very sad today, but they could be saying it like this and really happy and laughing with people. Well, then their affect is like bright, or, happy, but their mood is sad. So sometimes it is not always congruent. Then we want to look at their thought process and their thought content. So we'll go over this a little bit more, but the process is the way in which they're thinking, and we're going to go over that. And content is what they are thinking about. And the way you're able to assess thought process and thought content is sometimes asking questions, specifically the content, right? People aren't going to just tell you exactly what is on their mind. That is why it's important that we ask questions. We're also going to look at cognition, judgment and insight, and reliability. So when we talk about a general description, the appearance, right? We want to look at their age and gender. Do they look younger or older than their stated age? I've had patients that are my age and they literally look 65 years old, right? That tells us a lot about their ability to care for their ADLs, to care for their health, their maybe living conditions, and their ability to take care of themselves. So it's important that we look at that. Body build, are they very frail? Have they not been eating? Are they muscular? Are they obese? Can they take, again, this lets us know, are they taking care of themselves? Their appearance and the way that they're dressed. So are they appropriately dressed for the season? Sometimes we get patients, it gets very cold in Massachusetts, right? It can be like -20 outside. And we'll have patients come in with shorts and a t-shirt, right? Because that's all the clothes that they have. Or maybe they don't even realize that it's cold out. You ask them, why are you wearing shorts and a shirt? And not once are they like, this is all I have. I know it's cold out. They might be like, because I like them. I like how it feels. They're not even oriented to that it's freezing outside, right? So all of these things are important for us to look at. Are they childlike? Oftentimes when people have traumatic childhoods, sometimes they can get stuck at a certain age range, or it could just be a brain wiring sort of issue. Are they bizarre, that's going to tell us also what maybe different diagnoses we could be looking at. We want to look at their grooming. Again, are they taking care of themselves? And then any physical abnormalities. So like in a substance use population, we can look at the pupils, are they dilated or are they pin size, right? That could kind of let us know what kind of drugs may be in their system. Be leery of this because sometimes prescription medications can also make this happen. Also, pupil size is important to look at because if something neurological is going on, right? If one pupil is really big and one is really small, we know something bad is happening in the brain. So this is important to look at. We might see bruises, needle marks, cuts, missing teeth, things like that. And again, this isn't 100% of the time that it's substance use, but it's just things that we could possibly see. And then signs of anxiety, we might see moist hands, perspiring, tense posture, wide eyes. We can also see some of these with withdrawal as well. So, thinking about that. Okay. Then we're looking at motor behavior. So this is important to look at, the way in which somebody moves. And that's because some of our medications, particularly the antipsychotics, can have something called abnormal involuntary movements. It can make people move in certain ways that it's involuntary, right? So it could be like pin rolling of the fingers. It could be, this is more of a severe one, but the neck turns to the side and the eyes kind of roll up. That can happen. It can also the antipsychotics can give people essentially Parkinson's disease. It's drug-induced Parkinson's, but we can see the shuffling gait, the stiffness, right? We want to look for all of that stuff. Tardive dyskinesia, so the abnormal movements of the mouth, which can be permanent if they're not detected. So it's important that we monitor for these and that if it happens, we do what we're supposed to do, which could be giving an alternative medication to treat it. It could be taking away or dropping down the antipsychotic that we're using. Again, it's a risk-benefit analysis. There are certain people that will require meds for lifelong. So you might not be able to take the medication away, but you could use a medication to treat it. There's various different things. We want to look at their eye contact, their body posture, their mannerisms, any compulsions or rituals, right? If they're feel like they have to flick the switch up and down in order to leave the room, like we want to watch for these things because that's going to indicate potentially like an OCD, right? Tics, any kind of slowing movements. So if we're seeing like a lot of slowing, we might have something called catatonia going on. Sometimes people are completely frozen. We'll talk about that more in later or different kind of lecture that we have going on. But, we want to look at that. That's kind of one of those big red flags for catatonia, which often goes missed. So, if we're seeing the slowing, if we're seeing very fast movements, somebody might be manic or they might have substances in their system. We want to look for as well anger and agitation. Are they very impulsive or don't care about social norms, right? That could potentially indicate maybe more of like a personality disorder. So like all of these things go into our diagnosis, but we have to observe these things in order to make those diagnoses. So some examples of motor behavior things we could see. So something called akaesthesia. This is an inner restlessness and inability to sit still. This is a side effect sometimes of our medications that we use. One particular is Abilify. This happens sort of often with Abilify. There is a medication to treat it. We use propranolol, but it is something to look for. So if you start somebody on Abilify and they're sitting in front of you and they can't stop moving their legs or they're like tapping their legs and they just can't, like they're just like bouncing, they can't sit still. They're like, oh, I don't know what's wrong, right? That's akaesthesia. It can also come out people who can't kind of report those things. It could come out as like an agitation because they have that internal restlessness. So we want to watch for that. Automatism. I don't know how some of these words are a little much, right? So this is a spontaneous verbal or motor behavior without patient awareness. So they might just be like making noises and things like that. Catatonia, we're going to talk about that later, but it's either extreme motor inactivity So that is, again, where they're moving very slow. Sometimes they'll literally be stiff, and you could like lift their arm up and they'll just hold it there. And they just don't move. They don't, it's just nothing, right? It could swing the other way and be a hyperactive catatonia, which we're going to talk about. It's also called like delirious catatonia. And these people appear to be, I don't know the exact word. I guess the word I'm going to use is out of their mind, very high energy, not making sense, screaming, throwing themselves on the floor. It's quite intense. It's quite sad. The thing is, and we'll talk about this more, but with delirious catatonia, antipsychotics are going to make it worse. You actually give high doses of benzodiazepines for both hypo and hyperactive catatonia. All right. So core athesis, again, we don't really necessarily use these words every day. So bear with me. So this is a movement disorder characterized by episodes of attacks of involuntary movements of the limbs, trunks, and facial muscles. Dystonia is that twisting of the neck we kind of talked about, or repetitive movements, or an abnormal fixed posturing. And then tremors are rhythmic, oscillatory kind of movements. We all know what a tremor is. All right, so when it comes to the abnormal involuntary movements, one way that we can detect this is we do the AIMS assessment. So this is an assessment that you'll use in practice to kind of detect if there are any involuntary movements. I mean, a lot of the times you can just see them. It's also a good way to track, like, are they getting worse? Are they getting better? This is kind of the purpose of assessment. So we're looking at the facial and oral movements. We're looking at extremity movements, trunk movements, global judgments, and then the dental status. So it takes about 10 minutes to complete. And it's important to do this because tardive dyskinesia can affect 20 to 30% of patients treated with neuroleptic medications. This assessment is 12 items. And it can be done by us trained clinicians. All right. Actually, we're going to go back once more. So when we're looking at this AIMS assessment, the things we are looking for. So muscles of the face. So we're looking for movements in the forehead, eyebrows, the cheeks, frowning, blinking, smiling, grimacing. Are they puckering their lips or pouting or smacking their lips? Are they clenching their jaw or like making a chewing motion? If you want to look for is their tongue moving around in their mouth. Sometimes patients will like stop talking and they'll kind of open their mouth and you can see their tongue like going in a circle. That would be that one. And so, again, we're looking for extremity movements, neck twisting, so different things like that. Those are what we're looking for. All right, so when we talk about speech is important because it really helps us to indicate what diagnosis is going on. So, is it rapid, regular, or slowed speech? We kind of went over this already. Is it very dull, right? If they have a blunt affect, that can signify maybe like a very depressed person. It could also be something on the schizophrenia or schizoaffective thing, right? Because to have a blunt affect, right, when you're talking in a very dull voice and there's no really movement on your face and nothing affects you, right, that is indicating to us something in there, usually, maybe catatonia even, right? But it's important to notice that because that, again, gives us hints towards what might be going on. How are they talking? And we're going to go over this a little bit more, but, how does their voice get higher or low? How are their pauses when they're speaking? Do they talk in a circumstantial kind of way or a tangential kind of way? We're going to go over that a little bit more. How are they articulating? All of these things are important. There are also dysarthria, which is a mechanical dysfunction of speech. Echolalia, which is meaningless repetition of another person's spoken words. And again, you can see this with catatonia. You can also see it with other disorders, but you might talk to the patient and say something and they might just start repeating what you're saying. logism. I don't know how you say these words, right? The making up of new words, which is what I guess sort of just did because I have no idea how to pronunciate this. So sometimes they might do that, or clang associations. They might talk in rhymes, which I actually kind of like when people do this because it's very interesting how the brain works and how they can just get things to rhyme as they're talking. It's very cool. All right. So we want to look at their attitudes. Are they cooperative or uncooperative? Are they presenting as hypersexual, agitated, pessimistic, over dramatic, kind of controlling, hostile, guarded, self-centered? Again, all of these things are important to know. Is it indicating a personality disorder? Is it indicating a mood disorder? We put all of these clues together to get to our diagnoses. All right, so we went over the difference between mood and affect. One of the things with mood is you can always use quotes when you're doing your mental status exam. Because again, you're asking, how would you say your mood is today, right? And then you can put in quotes what they say. All right, these are all the different things. These are just some examples, I guess, of what a person's mood could be. So euthymic is a normal display of emotions. Hyperthymic is an intense display of emotions. We know irritable, we know anxious. Expansive is extreme or elevated moods that may last for an extended period of time. Elevated or euphoric is an excited state of intense happiness. Apathetic is showing or feeling no interest, enthusiasm, or concern. Dysphoric is a profound state of unease or dissatisfaction, and then we know what depressed is. So when we talk about affect, so this is what you see, right? These can be things like elevated, full affect, constricted, blunted, and flat. We kind of went over when we say, kind of like the big thing here is when we say somebody has a flat affect, that means that there is no emotional response to emotional stimuli. You could literally tell these people that their whole family just died. That's like a terrible thing to put out there, but you could tell them that, right? And they would just be like, okay, there's literally no emotion. So that is flat. When we say blunted, it's kind of like a dull or restricted response. You'll still see some emotion, but it's not a lot of emotion, right? Let's say you tell them you just want $1 million. They might be like, oh, that's great. Okay. But like, that's a blunt affect, right? If you told anyone else they want $1 million, they'd be jumping up and down. They'd be, screaming. So, that's going to be blunt. And so again, it's kind of on this range. Motility, so shifting of emotional states. When we say that someone is labile, this is kind of an unpredictable, uncontrollable, rapid shift of mood. So 1 minute they might be crying and then 10 minutes later, they're laughing and like really happy, right? They're labile. Their mood is all over the place. When we say fluctuating, that can kind of be like mood swings. So maybe in the morning they were really happy, nothing particular happened, but then, they kind of few hours later, they were just like not super excited anymore. Maybe we're like sad. That's kind of like a fluctuating mood. We can have a stable mood and then we can have like a sluggish mood. And then we want to look at the appropriateness to context, right? Does their mood match the context? All right. So now we're going to talk about thought process and thought content. So how do we assess thoughts? We ask questions. That's part of our assessment. So we are going to ask things like, what has been on your mind lately? Are you worried about anything? Have you felt like life isn't worth living? Do things seem unreal to you? Do you think anyone is trying to harm you? Are there thoughts you're having a hard time getting out of your head? Sometimes you may ask, well, actually, you are going to ask more direct questions, right? These are kind of light questions, particularly, especially if you're like inpatient or in the emergency room where you're doing assessments that require more direct, right? So you're going to ask people, are you having thoughts about hurting yourself? Are you having thoughts about hurting anyone else? Are you seeing things that aren't there? Are you hearing things that aren't there? Are you feeling paranoid? Or are you feeling like people are following you or talking about you? Sometimes you have to ask a little bit more direct, but these are just some examples. All right. So when we talk about thought process, this is the way in which somebody is thinking. So are they goal-directed and logical? They have a linear progression of thoughts without veering off subject. Circumstantial is the inability to answer a question without giving excessive or unnecessary detail. We're going to go over this more. Tangential is wandering off the topic and never returning to it. Again, we're going to talk about this a little bit more. Loosening of associations is jumping from one topic to the next without an apparent connection between the two topics. So like 1 minute, maybe now we're talking about thought process, and then all of a sudden I'm just like, oh, my phone. I have the new iPhone. It's great. I love the iPhone. I think I'm going to go get a pizza later. That would be loosening of associations, right? We're jumping topic to topic. There's no really apparent connection between. Flight of ideas is like a rapid shift from one topic to another. Perseveration is the repetition of a particular response, word, or phrase, regardless of the absence or sensation of a stimulus. So, for example, somebody might be perseverating about, it literally could be anything. It could be like their boyfriend or their dog, right? They just can't stop talking about it. And even when you ask a question about something else, it always kind of comes back to that thing. And then thought blocking is like they just stop talking without an explanation. They don't answer the questions that you're asking. They just stop. All right. So we're going to talk about a logical idea. So this is when a person wants to make a point to someone, and to make that point, they connect logical thoughts leading to the final point. So start. I was home, and we're going to get to, and now I'm here, right? So a logical thought is going to progress like, I was home, I felt some chest pain, so I told my son, and he called an ambulance, and now I'm here. That is a logical thought. When we talk about a circumstantial thought, and the way I like to think about this is circumstantial is kind of like a circle. And so what happens is they veer off track, but they end up coming back around. So they do get to that final point when something is circumstantial. So where each point is logically connected but veers off the goal, and then the person is able to self-correct and get back on track. So I was home, I felt some chest pain, so I told my son. My son, maybe you know him, he's a doctor too. He always worries so much. What was my point? Oh yeah, and now I'm here. So that's a circumstantial thought. It starts off kind of linear, veers off track, but does come back around. When we talk about a tangential thought, this is the thought that never gets to that endpoint. They start talking, they veer off track, they never come back around, unless you directly ask them, unless you veer them back around. So I was home, I felt some chest pain, so I told my son. My son, he's really great. If only he'd settle down and have children. Do you have children? I have 5 boys, right? Never comes back around. You would have to be like, that's great, but I'm interested in how you got here. And then they'd be like, oh yeah. And then they would, possibly come back around. They may go back on a tangent, and you never get the questions answered that you are looking for. All right. So other abnormalities of thought. So speech and thought are connected. So some of these things we already talked about when we talked about speech. Some other things you might see, I'm going to skip the ones we've already talked about. So word salad is kind of like an incomprehensible mix of meaningless words and phrases. And that's it. We went over all these other ones. All right. So when we talk about thought content, so this is now what people are actually thinking about. These can be ideas, beliefs, preoccupations, obsessions. They can be logical, coherent, illogical, or even unable to comprehend what they're thinking about because it just makes zero sense. Thoughts can range from a rapid flight of ideas to literally no ideas. Like you ask people things and they just don't respond. They have no thoughts. So perceptual disturbances we can see are hallucinations. So when it comes to hallucinations, they affect our senses. So you can actually have hallucinations related to any sense. Granted, auditory hallucinations are the most common, but you can also have visual hallucinations. People can have tactile feeling. A common one for tactile is like feeling like bugs are crawling on your skin or like on your face. A lot of people, if they're withdrawing off of like methamphetamines, will get tactile hallucinations, which is probably very scary for them. Gustatory is taste. They might taste certain things in their mouth, and olfactory, they might be getting certain smells that aren't there. Some hallucinations are normal in certain settings. So hypnagogic, these occur during a drowsy state preceding sleep. So if you've ever had, like, you're trying to fall asleep and maybe you see like a shadow and then you fall asleep, right? That's normal. There's also pompic, which occurs during a semi-conscious state preceding when you awake. So if you've ever like woken up and like thought you saw something in your room and then you wake up and you're like, wait, it wasn't there. That is actually normal. It's like the states going in and out of sleep. People can have hallucinations. And also in children, magical thinking in children can cause them to, report hallucinations in a way that is normal for that age group. For example, a lot of kids have imaginary friends, right? That's normal. They're not having a visual hallucination. They have an imaginary friend. All right. So some more thought content. We're going to talk about delusions. So delusions are a false fixed belief that have no rational basis in reality, being deemed unacceptable by the patient's culture. Okay. So delusions are interesting. So with delusions, people believe their delusions to their core. You cannot orient them in reality. Do not argue with a patient's delusion. Don't do it. It doesn't matter what you say. It doesn't matter if you bring all the receipts. It doesn't matter if you put together 100-page PowerPoint. It's just, 1 second. Sorry, my computer is having a meltdown. Okay. So it doesn't matter if you do all of those things, right? They will not believe you because a delusion, they believe to their core, regardless of what is based in reality. So there's different types of delusion. So the first one is a somatic delusion. So the delusions that one's bodily function, sensation, or appearance is abnormal. Delusions of grandeur So going back to somatic delusion. So for example, there's something called Cotard's syndrome where people actually believe like they're missing a limb. Like the limb is there, but they're like, no, I don't have it. Like it's gone. They also same disease that when people or syndrome, I guess, people believe they're dead, right? You could sit there all day and be like, look, you can see your heartbeat on the vital signs. Nope. They believe they're dead. That's it. It's done. That's it. So, right. Somatic delusion. Delusions of grandeur. So they believe that they possess some superior qualities such as fame, wealth, or supernatural powers, right? We know what that looks like. A paranoid delusion. So they believe they are being mistreated, usually persecuted. So like thinking people are out to get them. There's delusions of reference, where an otherwise significant event is misconstrued as having a special meaning specifically for them. For example, they could be driving down the highway and there is a billboard with a picture of a cat, and then they decide that that billboard is referring to them and means that they, have to color for 7 hours. Like, they don't make sense, right? Some of these, delusion of thought insertion. So delusions where one's believes that their thoughts are being externally placed from an outside party. So they think somebody is like putting thoughts in their mind. And then delusions of thought control, where they believe they're being controlled by an outside person or thing. Could be aliens, right? That's like a common one. People think they're being controlled by aliens. Delusions of thought broadcasting. So they think their thoughts are being known to everyone, that people can like read their minds and know the thoughts that they're thinking. There's also something called erotomanic delusions, where they believe it's typically a prominent figure or superstar, but it doesn't have to be. This is kind of common, I guess, with people sometimes who get stalked, where the person has a delusion that that other person is in love with them and that they are in a relationship, when in fact they're not, right? We've seen this on the news where like somebody will break into a celebrity's home and like be screaming like, we're married, I love you, whatever, right? That's that. They have erotomanic delusions. And nihilistic delusions are delusions where somebody believes that nothing is real. So other things that are part of thought content are obsessions. So people might have repeated intrusive and unwanted thoughts, images, or urges. We see this oftentimes with OCD. And sometimes OCD, you don't need the compulsions. You can just have the obsessions, the repetitive thoughts that are disturbing. And we'll talk about this more when we talk about diagnoses, but that's the big thing to kind of rule out. This is probably not the best example, but I'm going to give it. With OCD, repetitive obsessional thoughts that are disturbing. So if somebody is having really bad thoughts about doing bad things to people and they don't like those thoughts, they're saying like, I can't stop thinking about doing this bad thing to a person. I don't want to do it. That's not me, right? That's ego dystonic. It doesn't align with their ego, meaning like their self and the things that they truly want, right? So that would make me think OCD, right? Versus somebody who is like, I can't stop thinking about doing bad things to people, but I've wanted to. I always wanted to since I was a kid. I want to know what it would feel like, right? Now we're thinking personality disorder. Or depending on other symptoms, are they psychotic, right? So these are how we weed through different diagnoses. Compulsion, so repetitive behaviors, like they may think like, I have to flick that light switch. I have to flick that light switch. If I don't flick it, then my whole family, something bad is going to happen, right? Again, that's OCD, but that's the compulsion component. Preoccupation, so they might be so absorbed in their own thoughts to such degree that they lose contact with external reality. This can be preoccupied thoughts about hurting themselves, hurting others, phobias, so fear of an object or situation, again, thoughts about hurting themselves, thoughts about hurting others, depersonalization, so the loss of a sense of identity where the person's thoughts and feelings are no longer felt to be their own, or derealization, so a change in perception or experience of the external world to where it feels unrealistic. So sometimes we'll see this with a lot of dissociative disorders. People will feel like they come out of their body. They feel like nothing is real. They don't maybe know who they are. Their thoughts or feelings aren't their own, right? That's the depersonalization and derealization. All right. Then we look at cognition. And a way to kind of remember cognition is goal cramp. So what we are looking for is consciousness. Are they alert, drowsy, lethargic, stuporous, or comatose? Their orientation, to person, place, time, situation, their attention. To do this, we can ask them to spell world backwards or ask them to do something called serial sevens. And what we do is we ask them to subtract 7 from 100. So it'd be like 193. Oh my gosh, this is not 85. Yeah, 85, et cetera, right? So, see if they can do that. Language, so asking them to name objects, repeat words and sentences. So for example, what is this object? Ask them to name it. Calculations, can they add and subtract? We can have them draw a clock. If they draw a clock, you can see here. So the thing with cognition too is we're not doing this with every single patient. Maybe on the geriatric unit or somebody that you are thinking maybe that they have some dementia kind of brewing, right? You might do this, but you're not necessarily doing this with every single patient, but you can have them draw a clock. So you can see a normal clock. We can see this second clock is kind of an early Alzheimer's diagnosis, and then we can see the late Alzheimer's diagnosis. And this shows kind of problems with the right hemisphere of the brain. We can also ask them to draw these 2 pentagons. We'll show them the picture and then have them draw it. And you can see like a normal elderly person, a mild Alzheimer's, moderate Alzheimer's, et cetera, to severe, right? And it's very interesting that drawing a picture, we can make different diagnoses like this. And then abstraction, so explain similarities between objects, understanding simple proverbs. So what does the grass isn't always greener on the other side mean? And see if they understand that. That would be abstract thinking. And then memory, do they have immediate memory recall? So you could ask them to repeat a statement that you say, or like usually we do like 3 words, right? So you could be like pen, orange, cloud or something, right? And then see if they can repeat it. And then short term, you could also test short-term memory. So like at the end of this exam, you could ask them to repeat those 3 words again to see if their short-term memory is intact. And then praxis. So we can engage, apply, exercise in realizing or practice ideas. And if impairment is suspected on a mini mental status exam or a MOCA is most appropriate, they will test memory, calculations, funds of knowledge, and abstract meaning. All right. And then we look at insight. So do they have awareness and understanding of a situation, illness, and their availability of choices? Do they have capacity to understand and acknowledge and appreciate their illness, associate the implications of the illness, and then the consequences related to the treatments that they decide to ultimately select? And all insight can be affected by drugs and alcohol, dementia, psychosis, severe mood disorder problems, and somatoform disorders. So somatoform disorders are physical body symptoms in response to psychological distress. So I've seen somebody with, or I should say, I've seen patients with this disorder that maybe something traumatic happens to them physically. They never had a disorder before. Something traumatic happens physically to them, and then they start to exhibit the symptoms of this disorder. So there are 6 levels of insight. You don't necessarily have to memorize this, but at least, it's there. Some people will completely deny the illness. They might have some awareness, but also be denying. They might have awareness of the illness, but blame it on others or organic factors. They're not really taking accountability for maybe their part or their mismanagement. Awareness that the illness is caused by something unknown to the patient. They might have intellectual insight, and they may have true emotional insight. So judgment is the process of consideration and formulation that leads to a decision or action. The patient's capacity to make appropriate decisions and appropriately act on them in a social situation. So when we do our mental status exam, we'll put their judgment, right? They could have poor judgment, fair judgment. It all kind of depends on, their insight into their illness and them wanting to get better and what they think the future looks like. Like, we look at all of this stuff and then decide. There is never a black and white answer, right? I might do an assessment and say that somebody has fair insight. You might do an assessment and say they have good insight, right? It's kind of objective in that way. Or not objective, it's kind of subjective in that way. Assessment of judgment is best made by obtaining a patient's history and no correlation between intelligence and judgment. And then reliability, when you're doing your assessment, is this patient reliable? Like, in what they're saying? Is it believable? Is it true? Do they have the insight to be able, to give this information? Factors that affect reliability include intellect, honesty, motives, psychosis, and magnifying symptoms or understating symptoms. All right, so when we talk about the mini mental status exam, this quantifies cognitive status. Some components of the mini mental status exam include concentration and attention calculations. So again, doing those serial 7s, orientation. So knowing, what year, season, day, or month it is. The registration or ability to learn new material or say names of 3 unrelated objects. So again, what we talked about kind of in that cognition section. Recall, so we give them 3 words and then ask them to recall it later. And then fund of knowledge, we can ask something like, who is the president, see if they know it. Other instruments to assess cognitive impairment include the MOCA, the mini-cog, and the St. Louis University Mental Status Exam, or the SLUM. All of these we are going to talk about when we talk about screening tools and different exams. There's a whole talk on that, so we'll talk about it more there. So we talk about components of a psychiatric interview. So when we're interviewing a patient, things that we want to know. So this is kind of like your admission assessment. Identifying data, chief complaint, history of presenting illness, past medical history and psychiatric history, family history, current and past substance use. We want to know social and personal information, so where they live, any concerns living there, violence, marital and relationship status, educational history, occupational history, legal history, military service, religion, hobbies, social activities, family relationships, trauma history, and review of systems. So the first thing we're going to talk about when it comes to review of systems. So we want to do a neurological exam. So one part of that is reflexes. So reflexes, we want to note symmetry between the right and left sides. We want to check for primitive reflexes if we're looking at an infant. For example, a positive Babinski is normal in an infant and up to age 2. Anything after that would be abnormal. So again, with these long words, diadocornichesia is the ability to perform rapid alternating movements, and the client should be able to do this smoothly and execute these movements and maintain a rhythm. Dyssynergia is a finger to nose test or a heel to knee test. We can also do a handwriting test, and we want to look at their gait and observe how they walk. So in neurological exam, there's also something called the Romberg test. So this is looking at equilibrium. So the client will stand with their eyes open until stable, then close the eyes. They should be able to maintain this position with their eyes closed for 20 seconds. We want to stand close to the client to make sure that they don't fall. And we want to observe for any swaying or falling or widening their base of stance. A normal finding, this would be a negative Romberg test. That means it's normal. They're able to maintain posture and balance with their eyes opened and then also with their eyes closed for 20 seconds. An abnormal finding would be a positive Romberg test where you see kind of a swaying, and this suggests a cerebellum ataxia or vestibular dysfunction. You'll see kind of unsteadiness with eyes open, indicating cerebellum disease, and they can have a loss of steadiness with their eyes closed, indicates posterior column disease. So we can see over on the side, that is a negative Romberg test. They're wobbling. You do not need to remember, if they close their eyes and they're unsteady, then that is this disease. And if they're unsteady with the eyes open, that is that disease. Don't get lost with the advanced health assessment stuff. Don't get lost in the fine details, because on the exam, you're not going to get tested on the fine details. You're going to get tested on the basic overall principle. As psychiatric mental health nurse practitioners, we need to be able to identify when something is wrong, but we are not necessarily diagnosing those things and treating those things. We are referring them out. So know the Romberg test. Know when it's positive and negative. Don't get caught up with these super nitty-gritty details. All right, so cranial nerves. I will say, I memorized all the cranial nerves, and then when I got to the exam, I was surprised to find that, at least for me, it told you what the cranial nerve was. So it would say first olfactory, right? So that was nice. So just so you guys know, but know kind of the basics of what they do. So the way I remembered the cranial nerves is I like Harry Potter. So I found this one that goes with Harry Potter. So if you remember this little phrase, right, it will tell you which one goes with which, somewhat, right? It will give you the first letter. But again, you don't necessarily actually have to remember which one goes with which, at least from my experience. But you should know what they are and what they do. But if you did want to remember, so how I remembered it is on they traveled and found Voldemort guarding very ancient Horcruxes. And that's the first letter of each one. Then I would remember 1 is nose, you have 1 nose, 2 is eyes, you have 2 eyes. And then we'll keep going. But that, because there's quite a few O's at the beginning. All right, so olfactory tests your sense of smell. You can have the client close their eyes and put something under it and see if they're familiar with the odor. You could have a peppermint essential oil or something if you were going to actually do this assessment. Optic is testing vision with so number 2 is vision with a Snellen chart to see if they can see. Examine the inner aspect of the eyes with an ophthalmoscope, I'm not sure exactly how you say it, and test peripheral vision using the confrontation test. So we're going to talk more about these. Ocular motor is number 3. So you can think 3 is like movement around the eyes. So this is checking for equality of the pupils, their reaction to light, and their ability to accommodate. So again, you put your hand up, shine a light in one pupil, see if both the pupils kind of accommodate together for that. And test the corneal light reflex and the symmetry of both eyes. Trochlear, this is the same process as what we just talked about, and we're looking for, it's just the abductions of the eyes, so the eyes being able to move in. Trigeminal, this is the face, essentially. You can palpate the masseter muscles with your, again, I don't know how to say half these words, guys, with the fingertips while the client clenches his or her teeth. So you're just putting your hands here, ask them to clench their teeth, see if you feel it. Look for, movement of the lips, any of those TD symptoms we talked about. So that is the trigeminal for the motor. For the sensory, you can check the tactile perception of the facial skin by touching with a wisp of cotton. You can test the corneal reflex with a wisp of cotton, test for pain with a pinprick, and test for sensation of touch as well. So it's the face, essentially, for sensation on the face. All right. Abductions is the same process for cranial nerves, 3, so and 4, I guess. But it's the eyes being able to move out, right? So we just ask them to look each way and see if the eyes move. Facial motor, so inspect the face for a response for evidence of flaccid paralysis. So is one side kind of droopy? You can ask them to raise their eyebrows, wrinkle their forehead. And then we have facial sensory. So can they taste something sour, vinegar, or salt? Vestibular cochlear. So this is hearing, are they able to hear if you whisper? We can do a Weber's or a Rhine test also. Are we as nurse practitioners doing this? Honestly, we're not, right? Typically in practice. Well, we are, but we're not doing like a Weber's and Rhine test, right? But we're making an observation, right? Are their eyes moving normally? Is one side of their face drooping? Does one pupil dilated and one not, right? We're just like naturally doing this assessment, right? It's built in for us. But we're not going like super in depth. So don't worry about some of this stuff. But just kind of know the basics of what the, neurological exam is, what each one does sort of, and just kind of know that. So glossopharyngeal, so we can also test this with number 9. You'll ask them to open their mouth, stick out their tongue. The vagus nerve, so test for elevation of the uvula. So having the client open their mouth and say, and see if their uvula lifts up. Number 11 is test the strength of the sternocleidomastoid intraepiphyseal muscles. So you put your hands on their shoulders, ask them to lift their shoulders, essentially. Hypoglossial, so look at tremors and other involuntary movements when they stick out their tongue. And also, just to go back, for 10, that's swallowing. So are they swallowing normal? And you can tell, that's why I also put this picture over here. Sometimes if you're a visual learner, this really helped me to remember where each thing was. So you can see number 11 is the shoulders of the face, 10 is the swallowing, 9 and 12 is the mouth and the tongue, 5 is the whole face, 8 is the ears. And then you have kind of the eyes, or the 2, 4, 6, 3 kind of situation that's going on. Alrighty. So now sensory function. So we can apply pins to the skin simultaneously and ask if they feel 1 or 2 pricks. The inability to perceive movement might indicate peripheral neuropathy, lesions, or posterior column sensory cortex or the thalamus. Motor functions, so muscular mass. So we can measure muscular mass for atrophy or hypoatrophy. We can look at the tone of their muscles when they're resting, and we can check their muscular strength. Sometimes we can have them, if they're sitting down and they have their feet up, you can put your hands to their feet and ask them to push their feet and see like if one side is stronger than the other. That might indicate something. You can also have them grab your fingers and squeeze, and you can see if one side is higher than the other or stronger than the other. All right, so cerebellar function test. So looking at fine motor movement, we can use a fingertip to nose test. So we can have them sit with their eyes open and their arms outstretched, and then ask them to first take one index finger, touch their nose, and then rapidly alternate both sides, right? So you can see the picture there. And we have them repeat with their eyes closed. Then we can do a finger-to-finger test. So they touch their index finger to their own nose and then to the examiner's finger. We want to hold the finger about 18 inches from the client and have them move their finger to different spots 3 to 4 times. All right, so those are the 2 cerebellar function tests. All right, so another one, we can test rapid alternating movements. So we can have them sit and have them rapidly pat their knees, or first with their palms down, then with their palms up, repeat the movements several times, increasing the speed. Normal finding is that they will be able to perform all 3 of these tests that we talked about smoothly and rapidly. Abnormal findings would be any jerky or irregular, uncoordinated movements called dyssynergy. If they misjudge the distance, range, or speed, this could be dysmetria. And if they are unable to perform it and cannot rapidly stop one movement to perform the opposite, this could indicate a lesion to the posterior lobe of the cerebellum. This is dysdynokinesia. Again, do not get caught up with these vocab words. These are just because like we're reviewing it. So like, let's talk about it so you have all the information, but just know what's normal and abnormal, right? Pretty straightforward. All right, so when we talk about sensory tests, we kind of talked about this with the nerves. So a light touch, usually we have that we can have them close their eyes and maybe on their foot, we touch one side with a soft cotton ball and ask when they feel it. Again, if they don't feel this, it could be a peripheral neuropathy or something like that. For pain, we can use something like pointy and see if they can feel that. We can ask them to perceive, is it a sharp or a soft, or a dull sensation, depending on like which side you can see, which the 2 sides that the person is using. We can also use something like for temperature, if it's cold or hot water, right? We're just seeing if those senses are working. All right, then we can also do a vibration test. So set a low pitch tuning fork, place the stem of the vibrating fork firmly against a bony prominence. Ask the client to say now when they perceive the vibration, and then to report when they no longer receive the vibration. We can test each distal extremity. A normal finding is that they should feel the vibration over bony prominences. Abnormal finding is if they cannot, which would indicate neuropathies or spinal cord lesions. All right, then there is something called stereognosis. Again, not good with these words. So we have the client close their eyes and we put a familiar object in their hand. So for example, you can see the key, and then we ask them to identify what that object is. So some people, if something is going wrong, they won't be able to identify what the object is. Graphthesia is when we have them close their eyes and using a blunt tip, we trace a number on their hand or a shape and ask them to identify what it is. Normal findings is they should be able to feel the object, know what it is, and they should be able to read the number or shape written on their hand. Stereogenesis would be an abnormal finding, which is the inability to identify a familiar object. And agraphisia is the inability to distinguish written words on their palm, and it indicates something with a lesion within the sensory cortex. All right, so physical exam, things we're looking at. We're looking at vital signs, height, weight, blood pressure, growth charts for kids. We all know what vital signs are. I'm not going to go over it. So greater than 85th percentile for body mass index will place a child at an increased risk of being overweight. We want to look at BMIs of patients. High BMI is a risk factor for, diabetes, heart disease, stroke, hypertension, osteoarthritis, and some forms of cancer. We want to remember that some of our medications that we use do have metabolic side effects. So we want to be mindful of, these things. All All right, so the next thing we're going to look at is the hair, skin, and nails. So we want to note the color, integrity of the skin and whether lesions are present. Note if the skin is well hydrated, dry, or scaly. Assess for skin tuger, so meaning like when you take someone's skin and you pull it up, right? See how mine just kind of bounces back and does it? Yeah, bounces back. So that's good skin tuger. If that skin stayed up, I'm dehydrated, not good. The skin temperature, unusual moles or lesions, look at hair texture and distribution, determine the quality of the nails. Is there any splitting or clubbing or onychosis, again with the words. Check capillary refill. This is basic kind of nursing. Examine the head, scalp, sutures, or fontanelles, depending the age. And cancerous moles can be detected using the ABCD acronym. So a mole that has asymmetry, border irregularity, color variation, and a diameter greater than 6 millimeters and an elevation. All right, so now we're going to talk about skin lesions. All right, so a macule. This is less than 1 centimeter, something like a freckle. Then there is a patch. This is greater than 1 centimeter. We can think of things like port wine stains. They're usually purple, red, macular, vascular, and a malformation of dermal blood vessels. That is what a patch is. Then we can have a papule. So this is smaller than 0.5 centimeters. It is a solid elevated lesion. Example could be seborrheic keratosis or nevi. Then we can have a plaque. So this is a solid and elevated lesion that is greater than 0.5 centimeters. It can be things like psoriasis, triggered usually by stress, trauma, infection, or drugs, often on the knees, scalps, and elbows. Again, you don't need to remember this. You're not going to get tested on like different skin lesions, most likely, right? But these are like important things to know and understand if you're going to be a nurse practitioner, because you need to be able to identify them in your patients and kind of have an idea of what could maybe be going on and then be able to refer out. Okay, so then a nodule. This is a solid and elevated, hard or soft, deeper than a papule. It's usually 0.5 to 2 centimeters. An example is erythema nodosum. A tumor is the same as a nodule, but it's bigger than 2 centimeters. So example, we can see the picture there. That would be a tumor. And there's something called a wheal. This is a superficial raised erythematous, slightly irregular shape due to edema. Example are things like an insect bite or an allergic reaction. Then there are hives, which is a wheal which has I don't know what that word is. Again, some of these words, often extensive and pruritic. So we can see kind of the example over on the side. Fluid-filled lesions. So the first is a vesicle. This is less than 0.5 centimeters, is clear fluid trapped between superficial layers of skin. We can think of things like herpes simplex or zoster or scabies. Then there is a bulle, which is the same as a vesicle, only it is greater than 0.5 centimeters, and it can be something like a blister. Then there is a pustule, which is a vesicle, which is filled with purulent fluid. An example is like acne, impetigo, folliculitis. Cysts or elevated encapsulated cavity filled with greater than 0.5 centimeters of purulent fluid. Examples are a cyst. 20 to 40% of teens will get these related to androgens and bacteria and stress. We know a lot of teens get acne, right? All right, so a scale, these are now we are into secondary skin lesions. So a scale is a heaped up keraticized cells, irregular, thick, thin, dry, or oily with varying sizes, usually leading to flaky skin. This can be after scarlet fever or drug reaction or seborrhea. Then crust are dry blood, serum, pus on the surface of the skin. This can be a honey-colored crust of impetigo, usually in kids, and usually due to a strep or other infection. There can be a scar. This is a thin to thick fibrous tissue, replaces normal tissue after injury or laceration to the skin. Keloid is a progressively enlarged scar tissue resulted by excessive collagen formation during healing. Atrophic scarring is thinning of the epidermis. Examples are stria or aging skin. Lichenification is layers of thickened or roughened skin. Example is chronic dermatitis. Then there is excoriation, which is linear, crusted, hollowed out areas, abrasions, or scratches through the epidermis only. A fissure is a linear break going all the way to the dermis. Erosion is a circular loss of epidermis, moist following a rupture or blister. And an ulcer is a circular loss through the dermis. We can see examples of these. So when we talk about pressure ulcers, there are different stages. So stage 1 is when the skin is reddened but intact. It only goes down to the epidermis. When we get to stage 2, it can be with superficial or partial thickness skin involving loss of the dermis and epidermis. Stage 3 involves the dermis and full thickness skin loss. Damage or necrosis can extend down to, but not through the fascia. So we can see that it goes all the way down to the hypodermis. And then stage 4 is a full thickness ulcerization, which has extensive damage and necrosis to the muscle, bone, and or supporting structures. All right, so that was the skin. Now let's talk about the eyes. So we're checking for visual acuity with a Snellen chart. We're testing for peripheral vision using the confrontation test. So we are inspecting the sclera, or the white part of the eyes. We are assessing corneal sensation with the wisps of cotton. Again, testing those cranial nerves. We went over that. Assessing papillary reaction to light and accommodation. Assessing the 6 cardinal fields of gaze. So that is when we ask them to move their eyes, up and down, to side to get the 6 cardinal fields. Assess corneal light reflex, examine the inner aspect of the eyes with an ophthalmoscope. And psychotropics can cause blurred vision due to the anticholinergic effects, and quetiapine can cause cataracts. So just being mindful of this. When we talk about the ears, we're checking for configuration, position, and alignment of the ears. We test for auditory acuity with the whisper test or odometer. We inspect the external auditory canals with an otoscope for redness, swelling, or excessive earwax, essentially. Tympanic membrane should be translucent, pearly, and gray without retractions or bulges. So we can see down here, when you look into the ear with an otoscope, that is what the eardrum should look like. The heart, we're going to inspect, palpate, and auscultate the carotid pulses. So that is the artery right here. We want to, inspect it, make sure it's not like having jugular vein distension. We want to palpate it to make sure, obviously, there's a pulse. And we want to listen for any bruits, any irregular noises. We want to palpate peripheral pulses, check for symmetry, assess the heart rate, rhythm, and amplitude, check the apical pulses, palpate the precordium for pulsation or thrills. We want to auscultate heart sounds, and we want to assess for jugular vein distension. We're going to talk more about this. So this is kind of like an overview of a full kind of head to toe assessment. So we're using things of inspect, palpate, percuss, and auscultate. This is just like a nice overview. So when we talk about, we went over the face. Well, we went over, so we'll start with the head. We inspect and palpate the head, see if there's any, if their hair, is it dirty, all of those things, right? The face, we're inspecting for symmetry, looking for any lesions. We're checking, the airways. We're palpating the sinuses to see if there's any pain. We're inspecting the mouth, the mucous membrane, the uvula, all those things we just talked about, having them say, the eyes, we're inspecting to make sure there's no swelling, that the coloring is okay. Can they read a Snellen chart? Can they do they have constriction and consensual responses as far as the pupil and the movement of the eyes? We do a fundoscopic exam to look for blood vessels and retinal abnormalities. We do the cardinal movements. We're looking for things like pearla, so pupils are equal, round, reactive to light, and accommodate. When we look at the neck, we're inspecting for how it moves. Is the trachea midline? We can palpate the lymph nodes, carotid pulses. In the thyroid, you can place your hands on their neck. I can't really do it in this position, and have them swallow and see if it's like even, and if they're able to swallow or not. Inspect the back, palpate for tactile crepitus, percuss. They should have resonance and then be duller at the bases. Check for CVM tendencies. So that's when you put the hand on the lower back and you kind of hit it and note if there's any tenderness there for the patient. Oscillating lung sounds. On the front of the chest, we inspect it. Sternum configuration, make sure it's normal. Palpate for tactile crepitus. That's like feeling like if you can feel either air under the skin, like it'll make like a little bit of a crunch. Oscillating the lung sounds. Heart, inspecting for neck vein distension, palpating for thrills, any bruities, like hearing that whooshing in the jugular vein or the carotid. Oscillating the heart sounds, noting if there's any whooshing, things like that. When we look at the upper extremities, inspect, palpate any tenderness, any moisture, any swelling, palpating the pulses, checking cap refill, same with the hands, the lower extremities, very much the same. Muscular skeletal system, we can have them lie flat, inspect the symmetry of the legs, palpate the joints, have them lift their legs, have them cross their legs, create resistance and see if it's the same strength on each side, have them sit up, test the range of motions, arms up, down, all of these things. Inspect the curve of the spine, palpate the spine, their abdomen. We can inspect the skin, the contour, have them lift their head and cough, which would check for hernias. Oscillate, just make sure that you oscillate before you palpate on the abdomen, listening in all four quadrants for bowel sounds. We can percuss. It should have tympany over the stomach and then be duller over the liver and the right side. We can use light, medium, and deep palpation in all four quadrants and palpate the lymph nodes. And we went over the neurological assessment like in depth, so I'm not going to go over it again. But this is like a detailed summary of everything on 2 pages. So that is there too. All right. So we kind of went over this, right? Abdomen, we're inspecting, we're listening for the bowel sounds in all 4 quadrants. We want to make sure that we listen before we palpate, because once we palpate, we're going to get things moving. And then when we listen, it's not going to be accurate. Technically, you're supposed to listen for a full, you're supposed to listen for quite a bit for bowel sounds, and to have a full, no bowel sounds, you're just listen for a full minute. The normal is 5 to 30 noises per minute. Want to listen for any, the abdominal aorta for bruities, percuss the abdomen, notice any tympany or dullness, and percuss the size of the liver and the spleen. These are things we may see. So if somebody is obese, they're going to look like this. They might have something called ascites, which would look like this. They might have something called hepatomegaly, which looks like this. They might have something like an umbilical hernia, which looks like this. So when we percuss, we perform an indirect percussion in a consistent pattern over all 4 quadrants. Percussion is when you put your hand on it and you tap your hand and listen for a noise. When you hear something called tympany, this is heard over air-filled areas such as the stomach and intestines. When you hear a dullness, this will be heard over solid areas such as the liver or spleen or a distended bladder. Dullness to percussion over areas where tympany is normal may indicate that there's a mass or tumor, ascites, a full intestines, pregnancy, a full bladder, or an enlarged liver or spleen. When we palpate, we have them lay flat with their knees flexed up, which will relax the abdomen. We're going to palpate all 4 quadrants with the pads of our fingers. So light palpation is superficial, delicate, goes down 1/2 inch to 3/4 of an inch below the surface, and provides information on skin texture, moisture, masses, fluid. Muscular guarding and tenderness. Medium palpation is going to be 2 to 3 inches down, provides information about organs, masses, their shapes, mobility, and consistency. To test for cholecystitis, we press the fingers under the liver border at the lateral edge of the rectus muscle. So you can see a picture of it over there. We ask the client to take a deep breath. This should not be painful. If it is painful, this is called a positive Murphy sign, and this indicates inflammation of the gallbladder. Then we have an iliopsoas muscle test. As the client raises their right leg, we want to push down on top of the thigh and observe for any pain in the right lower quadrant. There's also an obturator muscle test, so we can have them flex the right leg at the hip, rotate the leg internally, then externally, and observe for pain in the hypnogastric region. So for palpating the abdomen, a normal finding is no tenderness, rigidity. Their abdomen is soft and there's no muscular guarding. Abnormal findings are tenderness, which could mean inflammation, masses, or enlarged organs, rigidity, and intra-abdominal bleed. Muscular guarding or expiration may indicate peritonitis. The presence of a mass, bulges, or swelling could mean enlarged organs, tumors, cholecystitis, hepatitis, cirrhosis. The liver should not be palpated below the costal margin. If palpated, it may indicate congestive heart failure, hepatitis, cirrhosis, encephalopathy, and cancer. And the spleen should not be palpable. If it is, it could be congestive heart failure, cirrhosis, mononucleosis, or inflammation. And recently emptied bladder should not be palpated above the symphysis pubis. If it is, it may indicate urinary retention. All right, so common abnormalities in the abdomen. So something like ascites, this is fluid in the peritoneal cavity. It's usually seen in people with advanced liver disease or liver cirrhosis. An aneurysm, so this is a sac formed by the dilation of an arterial wall. There's also something called a hernia, is a protrusion of an organ or another part of an organ through the cavity wall that it is contained in. You can have a bowel obstruction. When this happens, bowel sounds will be increased or high-pitched at first, but then go silent. So like before the obstruction, you'll hear these noises, and then after the obstruction, there will be nothing. And then appendicitis, so sudden pain may indicate rupture of the appendix and may lead to peritonitis. All right, so then we need to do a musculoskeletal exam. So assess the client's posture for alignment of the extremities and the spine and for symmetry of the body parts. Test the muscular strength of the upper and lower extremities. Note the symmetry of muscle tone and strength. Assess active range of motion in the neck, upper and lower extremities, and note any presence of pain with movement. Palpate the muscles in the joints to elicit pain, deformities, crepitus, and passive range of motion. Check for hip dysplasia in infants and check for scoliosis in children and adults. Indications of physical child abuse. So if we get kids that have a history of unexplained multiple fractures, burns on the hand or bite marks, injuries at various stages of healing, evidence of neglect, and bruising on padded parts of the body. So diagnostic and laboratory testing, this is another part of our health assessment that we are going to do. So diseases that have decreased thyroid levels include primary hypothyroidism, secondary hypothyroidism, tertiary hyperthyroidism, thyrotoxosis due to T3, renal failure, Cushing syndrome, and cirrhosis. Interfering factors, so values can be increased during treatment with heparin, aspirin, or propranolol, and values can be decreased during treatment with furosemide or methadone. So thyroid stimulating hormone, so stimulation of the thyroid gland by thyroid stimulating hormone causes the release and distribution of stored thyroid hormones. So when T4 and T3 are high, then TSH secretion decreases. So I just always remember that T3 and T4 are inversely related to TSH. So when one is high, the other is low, and vice versa. So when T3 and T4 are low, TSH secretion increases. In primary hypothyroidism, TSH levels rise because of low levels of the thyroid hormone. So this you need to know for the exam because there's so much overlap between hypothyroidism thyroidism and depression and hyperthyroidism and mania that the board, I believe, in my view, wants you to know what labs indicate hyper and hypothyroidism so that you can identify those things, because sometimes you might get a patient who's depressed and they don't necessarily need an antidepressant. What they need is thyroid hormone because they have hypothyroidism. So important. So know that when there is low levels of T3 and T4, we're going to see high TSH, which is going to indicate hypothyroidism. If the pituitary gland fails, TSH is not secreted and blood levels of TSH fall. The thyroid gland also stores T3 and T4 unless they are released into the bloodstream under the influence of the thyroid stimulating hormone, which is released from the pituitary gland. All right, so diseases with increased thyroid levels include hypothyroidism and thyroiditis. So we can see in this nice little chart over there that low T4 leads to high TS, and high TSH is usually from untreated hypothyroidism. When you have high T4 and a low TSH, that is going to lead to untreated hyperthyroidism or hypothyroidism treated with excessive medication. So then it swings them the other way. So diseases that have decreased thyroid levels include hyperthyroidism. Interfering factors. So values can be decreased during treatment with T3, acetylsalicylic acid, corticosteroids, and heparin, and values can be increased during drug therapy with lithium. Systemic effects of hypothyroidism mimics depression. So confusion, fluid retention, decreased libido, muscle aches and stiffness, impotence, decreased appetite, slowed reflexes, memory loss, somatic discomfort, lethargy, constipation, slowed speech and thinking, headaches, slower, clumsy, sensory disturbances, syncope, cerebellar ataxia, weight gain, and loss of amplitude in an EKG. When we have hypothyroidism, this reduces systemic cellular energy and releases all signs and symptoms that are so the signs and symptoms are reversible with treatment of hypothyroidism. A way to remember the common side effects is to remember that mom's so tired. So memory loss, obesity, menorrhea, slowness, skin and hair dryness, onset is gradual, tiredness, intolerance to cold, raised blood pressure, energy level fall, and depression. There are three kind of different areas that can cause this. So we can have Hashimoto's thyroiditis, which is an autoimmune condition. It can be a post-radioactive iodine treatment. So people who have had like thyroid cancer or Graves' disease that are treated with radioactive iodine, which then like injures the thyroid. Now the thyroid is not making the hormones that it needs to. Now they have hypothyroidism. And then medications can cause hypothyroidism. So this is a big one, lithium, right? We use lithium. Lithium does injure the thyroid. Over time, patients will probably need supplementation of thyroid hormone. Also amiodarone, interferon, and others. So now that was hypothyroidism. Now we're going to talk hyperthyroidism. So the thyroid is working too much. There's too much hormones, but the TSH will be low, right? Because when there's too many hormones, we don't need the thyroid stimulating hormone. It doesn't need to be stimulated. It's already overstimulated, right? So this can mimic the effects of bipolar disorder. So the mania particularly, because we're going to see restlessness, increased appetite, emotional lability, abdominal pain, short attention span, sweating, compulsive movements, flushing, fatigue, elevated upper eyelids. Their eyes get really wide. I don't know if I put a picture in here, but you can pretty much see the whites at the top and the bottom. Tremors lead, so tremors, insomnia, impotence, tachycardia, weight loss, dysrhythmias, and electrolyte imbalances. During hyperthyroidism, there is excessive cellular energy release, but all these signs and symptoms are reversible once they get the right treatment. So we can remember the signs and symptoms of hyperthyroidism with the acronym SWEATING. So We're going to see sweating. We're going to see weight loss, usually around 10 pounds, emotional lability, mind racing, memory alterations, appetite increases, but losing weight, tremors, tachycardia, intolerances to heat, irregular menstruation, irritability, nervousness. We can see a goiter. So that is like an enlarging of the thyroid in the throat. GI problems. Hyperthyroidism can be caused by various things. So the first is Graves' disease. This is autoimmune in nature. Toxic adenoma. This is a metabolically active lesion that is usually benign. Thyroiditis is a viral or autoimmune or postpartum disorder. And medication use. So amiodarone and interferon. All right. The next condition we're going to talk about that we may see is diabetes. We all know what diabetes is. We've all been nurses for a long time, so we don't need to get super into this. But, the glucose levels, we can have hypoglycemia, usually less than 55. When this happens, we'll see tremors, palpitations, anxiety, sweating, hunger, paresthesias, cognitive impairment, and behavioral changes. When we see hyperglycemia, also called diabetic ketoacidosis, usually between 350 and 500, we'll see polyuria, polydipsia, weight loss, neurological symptoms, lethargy, and can lead to even coma. Okay, so also electrolyte imbalances. Again, this is a lot of information, right? Do not, again, I'm just going to harp on this. Do not get so hemmed up in the details of this lecture, right? This information, it's a lot, but just know the basics of everything. Don't get super hemmed up in all the details, because truly you're going to be mostly tested on the psychiatric care of people. But I would definitely know the hypo and hyperthyroidism stuff, because that is related to psych, because there is a lot of overlap in symptoms. We want to make sure patients are getting the right treatment. We're not just treating everyone with hypothyroidism or hyperthyroidism with psychiatric medications, right? But, it's a lot of information to know. I understand that. I just don't want you guys to get too hemmed up. I know this is a lot of information. Okay. So these are nice little one-page printouts of the electrolyte imbalances. You should know this from nursing school. I'm going to just leave it at that. I think, so potassium might be an important one to know, right? Because we know that when you have hypokalemia, that needs to be treated first before anything else, because that it can lead to an arrhythmia, right? We don't want that to happen. Some of the signs you may see are things that might look psych, right? They might have anxiety, lethargy, confusion. Those are important. We want to note that. Hyperkalemia, we may see some of those signs from our neuro assessment, with the muscle twitching and weaknesses. And this is why we need to check muscle tone and strength and all that stuff. Sodium can be sort of related to psych, because when you have hyponatremia, you can have personality changes. So again, like that could look like something that might be psych related, but actually they just have hyponatremia, right? Again, anything with the sodium can affect the brain. So you can have like agitation, confusion, seizures. So again, we just need to make sure we're checking for these things, or at least having them follow up with primary care who can check for these things. If you're inpatient in the hospital, it's a little easier because they get the labs done there and you can like assess everything that's going on. But important to know. So hypocalcemia versus hypercalcemia, there's just some information there. You don't really need to go through all of this. Hypomagnesia versus hypermagnesia. We talked about some of this stuff, like with hypomagnesemia, we can see things like Trousseau's and Chauvik's sign, which would be like some twitching on the face, which is why we need to do those neuro assessments. But yeah, these are just some of the things that you could see. And phosphorus imbalance, so hypophosphatemia. So again, you can see some of the psych stuff. Irritability, confusion, seizures could be related to an electrolyte imbalance. And then hyperphosphatemia, you can see, disoriented, lethargy, again, could be considered psych stuff, but actually underneath that, there is something going on medically. All right. So now we're talking about liver enzymes. So we're moving on. Alanine aminotransferase, or ALT. It's an enzyme produced by the liver and acts as a catalyst in the transamination reaction necessary for amino acid productions. It's found in liver cells in high concentration and a moderate amount in body fluids such as the heart, kidneys, and skeletal muscles. When liver damage occurs, the level of ALT will rise to as much as 50 times the normal. Pronounced elevation can signify liver disease or damage such as hepatic cancer, hepatitis, or mono. Moderate elevated levels could mean that there is an obstruction, a recent cerebrovascular accident, muscular injury. This could be from intramuscular injections, trauma, infection, or seizure, muscular dystrophy, acute pancreatitis, intestinal injury, MI, congestive heart failure, renal failure, severe burns, and interfering factors. So uremia and hemodialysis can cause false decreased levels, and values can be increased when we use Tylenol, allopurinol, aspirin, ampicillin, carbamazepine, et cetera, et cetera. All these different drugs can make it increase. Then we have aspartate aminotransferase. So this is the AST. So this used to be known as serum glutamate oxalate transferase. Sure. AST measures the level of the enzyme that catalyzes the reversible transfer of amino acid groups between the amino acid aspartate and glutamic acid. You don't need to remember this. You just need to remember ALT and AST indicate liver function tests. And when they're elevated, that indicates there is damage or a problem with the liver. AST exists in large amounts in the liver and the myocardial cells, and in smaller but significant amounts in the skeletal muscle, kidney, and pancreas in the brain. When levels of this rise, it indicates there is cellular damage to the tissues in which the enzyme is found. So this could be acute hepatocellular damage, an MI, shock, pancreatitis, infectious mononucleosis. Moderate elevation can be due to arrhythmias, tumors in the liver, chronic hepatitis, biliary tract issues, congestive heart failure, muscular dystrophy, dermatosis failure. And a slight elevation, which is 2 to 3 the normal, could be due to pericarditis, cirrhosis of the liver, pulmonary function, delirium tremens, cerebrovascular accident, hemolytic anemia, and numerous drugs can affect the level, including hypertensive, cholinergic agents, digitalis, erythromycin, et cetera, et cetera. And exercise can cause increased levels as well. All right, then we have gamma glutamyl transpeptase, so GGT. It's an isoenzyme of alkaline phosphatase and assists with the transfer of amino acid and peptides across the cellular membrane. Hepatobiliary tissues and renotubular and pancreatic epithelials contain large amounts of this. Other sources are in the prostate gland, brain, and heart. It is used to evaluate and monitor the client with a known or suspected alcohol use, because levels rise even after ingestion of a small amount of alcohol, and can be used to evaluate elevated alkaline phosphatase of uncertain etiology. Pronounced early increases of GGP are found in hepatic diseases. Moderate elevations can occur in cirrhosis or pancreatic or renal disease. And elevated GT can be from hepatobiliary tract disorders, hepatocellular carcinoma, hepatocellular degeneration such as cirrhosis, hepatitis, pancreatic or renal cell damage, or neoplasm, congestive heart failure, acute MI, hypolipoproteinemia, diabetes with hypertension, seizure disorders, significant alcohol ingestion, and interfering factors can be the alcohol, barbiturates, phenytoin, and late pregnancy and contraceptives can lower it. All right, so one of the blood tests that we should be able to read, or a cluster of blood tests, is something called a CBC. So a a CBC. Okay. What we're going to look at is the hemoglobin. So for men, this is 14 to 17, and women, it's 12 to 16. If it's increased, it could be due to these things, and if it's decreased, it could be due to these things. Hematocrit, in males, it's 42 to 52, females 36 to 48. White blood cells are typically 5 to 10. If they're increased, this could be infection, mania, acute stress, leukemia. If they are low, it could be immunosuppression, medication-induced, nutritional abnormalities. Platelets should be 140 to 400. If they're increased, it could be a leukemia or inflammation, chronic hypoxia. If they are decreased, it could be splenomegaly. They could be clumping, all of these things. Neutrophils, so this is 1,800 to 8,000. If they're increased, it could be acute stress, inflammation, tumors, steroids, lithium, bleeding, seizures, all these different things. If it's decreased, it could be medication. So this is a big one. Clozapine. Clozapine can decrease neutrophils. We have to monitor this weekly. That's how serious it is. And if it drops, we have to stop it. We have to monitor the neutrophils and the white blood cell count. So that is one you should know, right? There's a lot of information in here. That's one you should know. Basophils, eosinophils, lymphocytes, monocytes, these are what it can be when they're increased. These are the levels that they should be. Just be aware of it. You don't need to memorize. All right, so chemistry profile overview. So then we're looking at different electrolytes, which we just went over. If they're high or low, what can kind of be the cause? So sodium should be 135 to 145, potassium 3.5 to 5, chloride 98 to 106, bicarbonate, calcium, phosphate, magnesium, the glucose, we went over that. BUN is 7 to 18, creatinine 0.6 to 1.3. We want to know creatinine and BUN because that is going to indicate kidney function. So that is important. Like, for example, certain medications like lithium, we want to be monitoring kidney function because it can injure the kidneys. Other medications like Depakote, we want to monitor the liver function because it can injure the liver. So that's why we need to know this stuff. All right. So speaking of liver function tests. So we went over the AST and the ALT. So example, AST and ALT with valproate therapy, also known as Depakote, right? We need to be monitoring these levels because if they start getting elevated, we could be damaging the kidneys with the valproate. You may see decreases in people who have chronic alcoholism. We went over the GGT. We know that that is related to alcohol use, alkaline phosphatase, ALP, so elevated in gallbladder disease, elevated with bone injury or rapid bone growth. We want to also look at, albumin, the total protein, the bilirubin. We went over ALT. We went over a lot of these. But again, these are just nice charts. Charts are very helpful. If you find a chart that you like, you can always print it out. So also want to look at ammonia, which will be elevated in severe liver disease or metabolic error byproduct of valproic acid. So again, we have to be looking at this stuff because we're giving these medications that can cause these problems for people. So it's our responsibility to be monitoring them. So thyroid panel overview. We went over the thyroid panel. So we have our TSH, that is our thyroid stimulating hormone. If there is not enough thyroid hormone in our body is going to increase the thyroid stimulating hormone to try to get more. So when you have hypothyroidism, which is going to be low T4 and T3, your body is going to increase the TSH. So remember, it's an inverse relationship. We went over this. All right, so psychotropic drugs. Some of these you should know. For example, lithium. You should know that the treatment for lithium, the blood level should be 0.6 to 1.2. Once you get above that, you start getting in trouble because you start getting into the toxic range. That you need to know. Carbamazepine, 4 to 12. I would say you don't really need to know that one. Valproic acid. This is another one that you should know. Anywhere between 50 and 125. But there are lots of different psychotropic kind of drug levels in the blood to know, right? Here is a nice chart. You could always print this if you like charts and, want it for your first job or whatever, it's good to have. But the big one to sort of remember is the lithium, because the range that is therapeutic is very close to the range that is toxic. So it's important that we know this so that we can adequately monitor it. All right, now we're going to talk about creatinine kinase. So this is anywhere between 0 and 139. It rises up with muscular injury because it's found in the heart, brain, and skeletal muscles. An elevated myocardial, it will be elevated in an MI. Can also be elevated in neuroleptic malignant syndrome. So that's a big one, right? Because that can happen due to our psychotropic medications. So this is another important one that we're able to identify. Can also be elevated after a restraint or something, right? Because of the skeletal muscle breakdown. So yes. All right. So kidney function test overview. So we kind of talked about some of this. So uranitrogen, so the BUN, this is an assessment of kidney function. It's increased in impaired kidney function or significant dehydration. We want to, again, measure with lithium therapy because we have to watch the kidneys when it comes to lithium. Creatinine, this is again an assessment of kidney function. It's more sensitive and more specific indicator of kidney disease than BUN, and again measured with lithium therapy. And glomerular filtration rate, this is the best assessment of kidney function. Elderly patients often have a normal creatinine, but a 30% reduced GFR because of reduced muscle mass. Generally, no dose adjustment or contraindications to use most psychotropic medications when the glomerular filtration rate is greater than 60. And the reason why it's a good measurement is because it's specific to the kidney. All right, so labs with psychotropic implications. So when we talk about some of the symptoms we see in psychiatric disorders, sometimes it can be correlated with the labs that we see. So for example, if somebody is reporting fatigue and low energy, and we may do a screen for depression, right? But then we may look at the hemoglobin and it could be 10, right? Which would be low, regardless if it's a male or female, right? 10 is low. The patient has anemia. That's why they probably have fatigue and low energy, right? So that's like something important to know. So again, the next one on our list, right? We have the hemoglobin is 10 and the mean cellular volume is 77. So this would indicate microcytic anemia. You don't need to remember this. It is not your responsibility to be like diagnosing anemia. But just for example, right? This could indicate like blood loss. But the big thing is like they're anemic. So that's where these symptoms are coming from, not because they actually have a neurotransmitter chemical issue in their brain. So again, another one. So hemoglobin is 10, mean cell volume is 105. They have macrocytic anemia. So this could be due to heavy alcohol use leading to a B12 deficiency or a side effect of some of the medications. So again, something important to note. Platelet of 70,000 could be thrombocytopenia, and it could be due to valproate therapy. So just important to note. Okay. So labs related to pharmacology. So valproate and select anti-epileptic drugs, such as carbamazepine. So we want to look at like liver panels, CBC with white blood cell differential, platelet count, serum HCG, and valproate level. We want to take the labs at baseline and then monthly for the first several weeks, and then every 6 to 24 months. Valproate levels should be 50 to 120. And complications we can see is that some people will have elevated AST and ALT between 2 and 44%, which like that's a huge range. Like I don't know, like when I was putting these slides together, that was the range that was given in the literature. That seems like a broad amount, but that's fine. Hepatic enzyme elevations most often occur in the first 6 months, more commonly in children, and AST and ALT will return to normal after the medication is discontinued. And we want to discontinue Depakote when the elevation is greater than 2 to 3% of the upper limit of normal, or 2 to 3 times the upper limit of normal. Sorry about that. With lithium, the initial labs we're going to do is a creatinine and BUN, GFR, TSH, serum electrolytes, CBC, diff. Want to make sure if they're pregnant or not, in a urinalysis, baseline EKG. Check lithium levels 12 hours post-dose after 4 days on the medication, and then every 4 to 5 days during the initial therapy. Long-term, creatinine and BUN, GFR, TSH, UA, CBC, a 12-hour lithium level, EKG if they're over 50 every 6 to 12 months, and then a lithium level. For acute treatment, it's 0.8 to 1.2, and for maintenance, it's 0.6 to 1. So clozapine, the big thing for this is the absolute neutrophil count. And it has to be monitored weekly, and it has to be put into an online system every week. So an ANC greater than or equal to 1,500 to initiate the therapy. If it falls below 1,000, we stop the therapy or we interrupt it. Special monitoring guidelines. So monitoring schedule of treatment, ANC is generally weekly for the first 6 months, and then every 2 weeks for the next 6 months, and then monthly if the ANC is less than 1,500 at any point. And prescribers have greater flexibility in continuing clozapine in patients with moderate to severe neutropenia. All right, so disease prevention activities. Immunizations are important, that we teach our patients about immunizations so that they don't get sick. So the flu vaccine, there's a lot of information there. Don't worry about it. HPV vaccines, in girls 11 or 12 years or older, measles, mumps, rubella, diphtheria, tetanus, pertussis, shingles, varicella, all of this kind of immunizations. We also want to give anticipatory guidance. So based on the premise of information can be provided to people to help them cope more effectively in events that occur along the lifespan. So pediatrics, soliciting information from the parents about their concerns with parenting and providing them with specific information related to their concerns. Bright Futures is a national health promotion initiative dedicated to the principles that every child deserves to be healthy, and involves trusting relationships among health professionals, the child and family, and the community, includes screenings, case management, and education. In specific healthcare situations, anticipatory guidance can be used to assist people in meeting healthcare challenges across the lifespan. So coping with a terminal illness, death, or dying, coping with disease progression such as Alzheimer's and dementia in a loved one, coping with changes and limitations resulting in spinal cord injuries, and can be implemented in each check to identify information, needs pertinent to the client's current life situation, can be used with domestic violence, life after loss, and planning for retirement. So gender-based medical testing and screening. So there is Tanner's stages of assessment. So this is like what we should see as children grow. You don't need to memorize all of this, but it is there in a nice chart if you want to look at it. When we talk about women ages 18 to 39, they should be doing monthly skin and oral self-assessments. Yearly, they should be getting their yearly physical, and they should be tested at least once for HIV. Women 40 to 49, literally same thing. They should be getting their pap smears, STI, and they should be getting an EKG every 4 years. Women 50 and older, so every 5 years, they should be getting a flexible sigmoid oscopy, and getting a hearing and vision test. That's the only addition. Men 18 to 39 doing their yearly physical, getting tested for STDs, and having at least one HIV test. Men 40 to 49, again, yearly physical. 50 plus, they should, same as women, be getting that colonoscopy, but they can also get a testosterone test and then a hearing and vision screening test. So health behavior guidelines, exercise is literally the best thing that we can recommend our patients. Exercise has been shown to help combat depression symptoms. It also has a good mind-body connection. It promotes increased concentration of serotonin, norepinephrine, and endorphins, which are all the same thing like our psychotropic meds do. It was really great. Client teaching regarding exercise. So, teach them to begin gradually, use both aerobic and strength training, monitor the intensity with their heart rate. Maximum heart rate is 220 minus your age. Physical activity at 60 to 70% of the maximum heart rate is considered moderate intensity exercise. The CDC recommends an hour of exercise or more for children and recommends 150 minutes of moderate exercise every week for adults. Self-awareness, so being able to reflect on one person's personal beliefs, emotions, motives based on limitations and being aware of how they influence behavior. A trusted person who can give open, honest feedback to self-examination is helpful. Personal experience influences communication patterns, social biases and feelings. Being non-judgmental and objective cultivates trust. Clinical supervision by a colleague can be helpful. And if your personal values or beliefs make it difficult to be in a therapeutic relationship with a particular client, you should refer them to somebody else. Self-disclosure is revealing personal information to the client that takes the focus away from the client. When asking personal questions, self-disclosure can be limited by redirecting. And self-disclosure may be therapeutic only when it's purposeful as identified by the therapeutic outcomes, such as role modeling. Healthcare promotion and disease prevention. So this is part of our role to screen for physical health problems in the psychiatric client and to help with mental health promotion, teaching them about interventions to cope, normalizing their feelings, helping them recognize and identify their feelings, and helping them find resources. Public health principles. So there is primary prevention. So this is important to know. There is primary prevention, which is aimed at decreasing the incidence of mental disorders. It helps people avoid stress or cope with them more adaptively. So examples is like stress management classes, graduate student classes. For graduate students, smoking prevention classes, drug abuse resistant education, keeping it real, elementary and middle school curriculum. So primary prevention, we decrease the incidence of mental health disorders by giving education like before it happens. Secondary prevention is aimed at decreasing the prevalence. So this could be early screening, early case finding, prompt intervention, treatment like hotlines, crisis intervention, disaster responses. I always remember secondary. The secondary is usually anything that's screening. So you're not primary is preventing. Secondary is screening. And then tertiary is aimed at decreasing the disability and severity. So this would be things like the problem has already happened. How can we make it like not as bad? So rehab things, day programs, special housing, case managers, that would all be tertiary. We want to think about patients' risk factors. So their predisposing characteristics make it more likely that they will develop a disorder. Biological risk factors, so looking at family history, nutritional status, their general health. Psychological risk factors, poor self-concept, external locus of control, poor ego defensive, social risk factors, so like stressful jobs, their socioeconomic status, preventative factors, so things that can prevent them from having the disorder, so things like coping mechanisms, biological factors, maybe they have no family history of mental illness, maybe they have psychological preventative factors, so like good self-esteem, self-concept, good locus of internal control, healthy defense mechanisms. And all right, that was a long one. I know it's a lot. Don't get too wrapped up in the details. Just know the basic overview. You'll only probably have a few questions based on this section. So focus more on the psych stuff, I would say. But know kind of like the basic things. Okay, thanks. I'll see you guys next time. Bye.